Topic is complications of sinusitis. As long as the infection is confined only to the sinus mucosa, it is called sinusitis. But complications are said to arise when infection spreads into or beyond the bony walls of the sinus. Now, which are the types? It can be local, orbital, intracranial, descending infections, and focal infection. Now, local. When there is mucosal or pyocil, mucopyocil, mucus retention cyst, osteomyelitis of the frontal bone and maxilla. Orbital is when there is preseptal inflammation, edema of the leads, supraorbital abscess, orbital cellulitis, orbital abscess, superior orbital fissure syndrome or orbital apex syndrome. Intracranial, when it leads to meningitis, extradural abscess, subdural abscess, brain abscess, and cavernous sinus thrombosis. Now, pathogenesis. Direct spread is through the walls of the sinuses. Venous spread is through the subepithelial venous plexus. Lymphatic spread is through perivascular lymphatics through the subperiosteal bone. Perineal spread is through the perineal space of olfactory nerve. Now, local complications. First is the mucosal paranasal sinuses and mucus retention cyst. This is a cystic swelling of the sinus lined by the mucosa and occurs as a result of permanent or chronic obstruction of the sinus ostium or the duct of the mucous gland. This leads to collection of the secretions of the gland or sinuses resulting in retention cyst. More commonly, it is seen in the frontal and ethmoid sinus. Here you can see there is a bulge over the forehead in the lower down, and there is a drooping of the eyelids and edema over the orbital region. Now, frontal sinus mucosa. It usually present in the superomedial quadrant of the orbit, commonly occurs as a result of obstruction to the frontal ostium due to chronic disease of the frontal recess or due to post-surgical or traumatic fibrosis causing blockage. That is frontal sinus mucosal. Clinical features are the supraorbital swelling, usually above and lateral to the medial canthus. Diplopia may be present due to proptosis. Headache is usually confined to the frontal region. Milder type, there can be proptosis. And the swelling is usually cystic and non-tender, and eggshell cracking may be elicited. Investigation. X-ray PNS will show the cloudiness of the affected frontal sinus and loss of scalloping. CT scan of the paranasal sinuses, and we have to do direct nasal endoscopy to confirm our finding. Treatment is endoscopic sinus surgery with frontal recess clearance and uncapping of the mucosal is the treatment of choice. Alternatively, external frontal ethmoidectomy, that is Lynch-Howarth operation or osteoplastic flap operation by bicoronal incision may be done. In case of pyocil, that is pus, within this mucosal, when there is collection of the pus, it is called pyocil. We need antibiotics before the surgery. Now comes the osteomyelitis. Osteomyelitis is the infection of the bone marrow, as it suggests that osteum and myelitis, that is bone and marrow, and should be differentiated from the osteitis, which is infection of the compact bone. It involves either maxilla or frontal bone. It will involve which bone which contains the bone marrow, that is maxilla and frontal bone. And now osteomyelitis of the maxilla. It is more often seen in infants and children because of the presence of spongy bone in the interior wall of maxilla. So it is seen mainly in the infants and children. Clinical features are the erythema, swelling of the cheek, lower lid edema, purulent nasal discharge and fever. Subperiosteal abscess followed by fistula may form in infraorbital region, alveolus or in zygoma. Sequestration of the bone may occur. We have to give large dose of antibiotics, drainage of the abscess and sequestra removal. Now, osteomyelitis of the frontal bone. It is often seen in the adults as frontal sinus is not well developed in the infants and children. It may result from acute infection of the frontal sinus either directly or through the venous spread. Pus may form externally under the periosteum as soft dewy swelling, that is Pott's puffy tumor, or internally as an extradural abscess. The treatment is large dose of antibiotic, drainage of the abscess and trephining of the frontal sinus through its floor. Sometimes it requires removal of the sequestra and necrotic bone by raising a scalpel through the coronal incision. Now, which are the orbital complications? Here in the picture, as you can see, when it is preseptal, that is called the area is marked with the color, that is preseptal. Then within the orbit, that is orbital cellulitis. Then subperiosteum, beneath the periosteum, that is subperiosteal abscess. Then orbital abscess. Most of the orbital complications follow the infection of the ethmoids, as they are separated from the orbit by only thin layer of the bone, paper thin bone, that is called lamina papyracea. Infection travels from this sinuses either by osteitis or as thrombophlebitic process of ethmoidal vein. Now this is the Chandler's classification. For as what we saw in the picture, the same is that, and the last one is cavernous sinus thrombosis. So how will you differentiate the stages? First, inflammatory edema, that is preseptal. So there will be lead edema, no limitation in the ocular movement or visual change. Only the lead edema will be there. In orbital cellulitis, there is diffuse orbital infection and inflammation without abscess formation. And here, subperiosteal abscess, there is collection of the pus between the medial periosteum and the lamina papyracea. There is impaired extraocular movement. Now within the orbital abscess, there is discrete pus collection within the orbital tissue. There is proptosis and chemosis with ophthalmoplegia and decreased vision. Because as the orbital structures is involved, so it will lead to chemosis, ophthalmoplegia, decreased vision, that is, it will lead to involvement of the nerve 2, nerve 3. Then later stages it will lead to cavernous sinus thrombosis. So from this sinus is through the venous plexus, it will go directly to the cavernous sinus. So bilateral eye findings are seen and worsening of all other previously described findings. Now this is preseptal inflammatory edema of the leads. As we can see here, only upper lid edema, rest everything is normal. And yes, upper eyelid is swollen in frontal and lower in the maxillary, or in the both leads in the ethmoidal. Subperiosteal, pus collection outside the bone under the periosteum. A subperiosteal abscess from the ethmoids form on the medial wall of the orbit and displaces the eyeball forward, downward and laterally, as you can see in the picture. And from the frontal sinuses, abscess is situated just above and behind the medial canthus and displaces the eyeball downwards and laterally, while from the maxillary sinus, abscess forms in the floor of the orbit and displaces the eyeball upwards and forwards. Now this is orbital cellulitis, that is when pus breaks through the periosteum and finds its way into the orbit, it spreads between the orbital fat, extraocular muscles, vessels and nerves. And its clinical features are lead edema, exophthalmos, chemosis of the conjunctiva, restricted movements of the eyeball with partial or total loss of vision, and patient might have high fever. Orbital cellulitis is potentially dangerous and because of the risk of meningitis and cavernous sinus thrombosis. Now orbital abscess, that is intraorbital abscess, usually forms along the lamina papyracea or the floor of the frontal sinus. Clinical features same as above. Diagnosis CT scan or ultrasound of the orbit. Treatment is IV antibiotics and drainage of the abscess and that of the sinus, that is ethmoidectomy or trephination of the frontal sinus. Trephination is when you make an opening through the trocar and cannula within the sinus opening and you drain the pus. Now, superior orbital fissure syndrome. As the name suggests, it will involve the superior orbital fissure. So, all the structures which are passing through the superior orbital fissure are involved. So, there will be deep orbital pain, frontal headache and progressive paralysis of the which nerves in order, that is 6th, 3rd and 4th. That is abducent, that trochlear and ophthalmic nerve. Then orbital apex syndrome, that is supraorbital fissure syndrome with additional involvement of the optic nerve and maxillary division of the trigeminal nerve, that is orbital apex syndrome. In the supraorbital fissure, only 3 nerves, that is 3, 4 and 6. With in orbital apex, there will be 2, 3, 4, 5 and 6. But in the 5, only this maxillary division of the trigeminal nerve. Now, intracranial complications. Frontal, ethmoid and sphenoid sinuses are closely related to the intracranial fossa, and infection from this can cause following complication. That is meningitis and encephalitis, extradural abscess, subdural abscess, brain abscess and cavernous sinus thrombosis. Now, what is cavernous sinus thrombosis? When infection of the paranasal sinuses and orbital complications from this sinus infection can cause thrombophlebitis of the cavernous sinus, which lead to abrupt onset with chills and fever, swollen eyelids with chemosis and proptosis of the eyeball. When 3, 4 and 6 now gets involved individually and sequentially causing total ophthalmoplegia, pupil becomes dilated and fixed, congestion of the optic disc and diminution of the vision, sensation in the distribution of the ophthalmic division of the trigeminal nerve is diminished. The treatment is IV injectable antibiotics and attention to the focus of infection, drainage of the infected ethmoid or sphenoid sinus. Now, what is the difference between orbital cellulitis and cavernous sinus thrombosis? Orbital cellulitis, as the name only suggests, it is limited to the orbits, but cavernous sinus is like when the brain is also brain structure, that is venous sinuses of the brain, cavernous sinus is involved, so it is a higher complication than orbital cellulitis, that is intracranial complication. So, first we will see for the orbital cellulitis. Commonly, it is related to the ethmoid sinus. It has slow onset. It starts with edema of the eyelids. Then it will inacanthus, chemosis and proptosis. Then it involved concurrently with complete ophthalmoplegia. Then laterality is often involves. Laterality is one side. That is only one side only, mostly. Then cavernous sinus thrombosis. So the source is nose, sinus, orbit, ear or pharynx. Any of the face or head and neck infections which can lead to the involvement of the vein which leads to the cavernous sinus. It can lead to the cavernous sinus thrombosis. It has abrupt onset with high fever, chills and signs of toxemia, edema of the eyelids, chemosis and proptosis. Cranial nerve involvement is individually and sequentially. It involves mostly both eyes. Now, descending infections. In suppurative sinusitis, the discharge constantly flows into the pharynx and cause or aggravate otitis media, pharyngitis, tonsillitis, that is hypertrophy of lateral lymphoid bands behind the posterior pillars, is indicative of chronic sinusitis. Then persistent laryngitis and tracheobronchitis. Focal infections. Sinusitis may act as focus of infection in conditions like polyarthritis, tenosynovitis, fibrositis and certain skin diseases. So, here comes to the end. Thank you.